I think we had some questions online after after Dr. Agulnik spoke, and maybe someone could read us those questions and we can ask Dr. Agulnik.
I'll pass this mic to Kaylee's.
Yes, so one of the questions was, are there any clinical trials targeting the following genomic mutations? KEAP1 or PIK3R1 for metastatic spindle cell sarcoma. When sending a tissue sample for genomic testing, does one go for the initial primary tumor or the metastatic tumor type, for example, pulmonary? Does the primary tumor mutation have any influence on targeted therapy? Is it usually the same mutation as the secondary sites?
Thank you. That's a great question. So there's several parts of the question. The first part is finding a clinical trial for a specific mutation. The initial diagnosis was made to when the metastatic deposit forms. Often the first sample has already been processed. It's either, you'd have to get some archival tissue out of it. Sometimes it's older than 6 months or a year is old. So my preference is always to get fresh tissue and use that fresh tissue for the testing.
And also, there are some trials called the taper or the match trial that they do match up some of those mutations as well. So, but that was very good because you can find that information from either your doctor or the clinicaltrials.gov or the report, as you say.
If you match, I will say, so the match trial or the taper are excellent ones. So what they're trying to do is match patients based on the genetic sequencing to a clinical trial. Often what will happen, and hopefully most companies are doing this, if you actually match to one of the trials, they will send a letter to your doctor to alert them that you have matched to it, and that will actually make things easier for you to be able to get onto one of those trials.
Thank you so much for answering those questions. Dr. D'Amato, there's a question in the chat that says, did the cutaneous angiosarcoma study drop the third arm?
I think was that about the, I think that was no.
Yeah, so this is the Alliance study that had 3 arms. The third arm wasn't dropped. The third arm is targeted therapy with immunotherapy. And that arm filled, and so the other arms were still left open. And so that was for patients that were previously treated with paclitaxel, and so they weren't eligible for the first 2 arms, and so they automatically went to the third arm, and the third arm has fully recruited at this point.
Thank you so much.
Yeah.
There's another question that says, I have PEComa that is metastasized from my uterus to both my lungs. Would either Keytruda or Ivermectin be of some help with getting results using other treatments also? I've read about some of these 2 drugs lately. I've been stage 4 for 2 years now.
So PEComa, as Dr. Forscher had talked about, is a rare type of sarcoma, and it has usually a specific gene mutation in the TSC pathway, the PI3 kinase AKT mTOR pathway. And recently there's been a drug that's been FDA approved for PEComa called nab-paclitaxel. And so that, or sirolimus, I mean, sorry, not nab-sirolimus, has been FDA approved for that, as well as there's some other mTOR inhibitors that we've been using, like sirolimus or everolimus. So I think the patient's currently on pazopanib. If the pazopanib is doing well, then continue on that. But if the cancer is getting worse, then you can talk to your doctor about the new drug that's available. I'm not aware of any data on the Ivermectin, but for the pembrolizumab, which is a immunotherapy, I'm not aware of anything for PEComa, but you know, maybe on a clinical trial if the nab sirolimus is ineffective.
Yeah, I agree completely. I think the other thing they could just certainly look at a NGS report, and if the tumor mutational burden is above 10, then potentially using some immunotherapy would make sense from a scientific standpoint. But again, finding a clinical trial or using the new FDA-approved medication seems to be the most reasonable thing.
Thank you so much. Another question was, what are the benefits of genetic or mutation testing, and do doctors usually prescribe treatment based on this result?
I tried to explain that in the Q&A, but I guess I'll take this one. Okay, so when we talk about the mutation testing or looking for NGS, the next generation sequencing, it can be helpful, and sometimes we don't get any information. Most of the time, it's not helpful, but sometimes it can be very helpful. So what we usually do is go with the standard treatment for the subtype of sarcoma, and then based on and then while we're giving that treatment, you can send the tumor specimen out for molecular testing. That usually takes 3 to 4 weeks at least. And then possibly we may be able to get a potential treatment out of that. Most of the time it hasn't been proven better than the standard therapy, but certainly there are some gene mutations that the targeted therapy could even be better than the standard. For example, if you get an NTRK mutation, it's very rare, but there are some drugs that target NTRK, and we have NTRK inhibitors. So sometimes it can be very helpful. So, but we don't normally replace standard therapy with those drugs.
The value of NGS, I think we're certainly learning a lot more about it. We recently published an article looking at thousands and thousands of NGS samples that were done for sarcoma patients, both soft tissue and bone, and looking at what impact does it have. When I was at, excuse me, when I was at Northwestern, we pulled the data from all the NGS samples that we did on our sarcoma patients and found that it was in the order of about maybe 12% of the patients we actually made a modification based on the report. Most of the modifications are clear modifications that would be obvious. It's very few patients that you find one of these outliers, and that's probably in the order of probably 3% or less. But if you're one of those 3% of patients, I mean, doing these sequencing of your tumor would be imperative. And it could certainly change the way you are treated in a very meaningful way.
So there aren't any more questions from the Zoom community. I'm wondering if there are any more questions from the room, and if so, raise your hand and I'll come to you with the mic. You're right there.
Thank you.
My question, I had to write it down. What is the frequency of checking on clinical trial patients? Just to see like how they're progressing, if it's getting better, or if it's something that's just not going so great with them. How often are they tested or examined?
So, each of the clinical trials will have certain protocols that will have a specific protocol, how often we test to see how the drug is working. Usually that's goes along with the standard therapies. So say if we have someone that's on chemotherapy and we want to see how it's working, we usually get scans every 2 cycles, which is usually every 6 to 8 weeks. We want to see how the treatment's working. So most of the clinical trials, you get tested pretty frequently, unless it's more of a slower growing tumor, at which point the tests are less frequent. So it depends on the trial, depends on the type of cancer, how often we check, but usually it's quite frequently because we want to make sure that the treatment's working.
Thank you. Anyone else? Yes, I'll be right there.
Hi, how does MDM2 fish affect the results of it? What does that mean in terms of treatment?
So the MDM2 is utilized to help with diagnosis. And so what happens is often you get a report from a pathologist and you get a preliminary report, and the ability to distinguish a sarcoma versus a carcinoma versus another condition is certainly able to be established. And then once they establish that the diagnosis is sarcoma, it's very important for us to understand what the histology is. And so if it's sort of bordering on this could be this, this, or this, they'll send off testing to rule things in or out. So often we want to rule in or out synovial sarcoma, and they look for translocation. They use MDM2 for the liposarcomas. They're using all the tools we have and all the testing we have in order to be able to establish, is something the right diagnosis, yes or no? When you get a full NGS report, often you'll have that there is a sarcoma type that may or may not be liposarcoma that has an MDM2 amplification. So too much of something. And so that is certainly something that could generate interest in some of the clinical trials that are currently ongoing. And so there are specific drugs that will come to market or are being investigated that are specifically looking at that as a target. And so it is important to know, irrespective of what the sarcoma subtype is, what is the MDM2, but predominantly what historically it has been used for is not as a marker for treatment, but a marker for diagnosis.
Yeah, we have some more virtual.
There's another question from the online community. For patients with pulmonary mets due to RP sarcoma, in parentheses, spindle cell, how long can one be on doxo? Is there any benefit to gem or ifos added on? Hopefully I read that right.
Yeah, so the question is, how long could someone with a retroperitoneal sarcoma that is metastasized be on any given therapy? And so just to generalize things, so there are a number of chemotherapies that are currently FDA approved and are readily used for the treatment of most soft tissue sarcoma patients. And so doxorubicin would be one of the key ones. It is one of few drugs that we have that most of us would feel that there's a limit in how many treatments one could get. There are some variations depending on what center you're at with how much that will be. I usually don't take someone more than about 600 milligrams per meter squared, which if you're dosing at a dose of 75, you get about 8 cycles in. And so for me, I usually stop after 8 cycles, but that's not everyone's different. Some people take it up to 6, some people go beyond 8. And so that to me is sort of the max to do. With respect to what is the role of gemcitabine, if you're getting doxorubicin, I gather that you could tolerate gemcitabine with the addition of taxotere, as opposed to just getting gemcitabine as a single agent. And so the benefit of the combination is that you have an increase in response rate as well as the progression-free time before the tumor grows if you take the combination. And the last one was ifosfamide. And so ifosfamide is a third drug that is used and certainly has value. It's a little bit more toxic, I find, than some of the other ones, but certainly there's a value for it in the treatment of a retroperitoneal sarcoma that's metastasized to lungs. And then certainly other drugs that one would want to think about is a targeted therapy like pazopanib, which could be FDA approved as long as it's not liposarcoma. And then there would be other drugs as well, like dacarbazine or temozolomide, and then clinical trials.
Thank you. We have another attendee who wanted to know which immunotherapy drugs are helpful for recurrent metastatic inoperable SEF.
Solitary, what's the histology?
It says SEF. I'm not sure.
So, yeah, so I think so if we're talking immunotherapy, so I would say in my practice, and Gina, I gather you would say that the number one question that people come in is, could they get immunotherapy? People are very interested in the role of immunotherapy. If we look at NCCN guidelines, which is the National Comprehensive Cancer Network, which is formulated by academic medical centers in the United States, and it would be populated by sarcoma specialists, both surgeons, radiation oncologists, medical oncologists, and pathologists. There is a subsection there where immunotherapy does have a role for patients with soft tissue sarcomas, and it's defined by the use of pembrolizumab for undifferentiated pleomorphic sarcoma, I think myxofibrosarcoma, cutaneous angiosarcoma. And I think those are the three histology that NCCN has listed. Any use of immunotherapy off of those three histologies could certainly be done. It becomes a little bit harder. Often you need the company to provide the drug free of charge on compassionate basis because it is not listed under, if it's listed in the NCCN as a recommendation, often the drug companies will then pay for it based on the listing in that listing of it. And so if you want to use it off label, if there's a good reason, so usually I use like a tumor mutational burden number. So if there is a reason to use the drug, you often just have to get it from the company.
Thank you so much. They also clarified that SEF is sclerosing epithelioid fibrosarcoma.
Okay. And you know, tune in because Dr. Pollack is going to be speaking about immunotherapy. So definitely tune in to his lecture after this.
Thank you. Somebody else asked, what does standard treatment mean? What's usually done, and has it been validated for rare cases of sarcoma?
Okay, well, that is a good question. I may have to add that to my vocabulary list in my Cancer 101 talk. So when we say standard therapy, we are talking about the treatments that we normally give for the cancer. And those standard therapies have come about based on clinical trials that were done in the past. So Dr. Agulnik talked about how the clinical trial process works. And so the treatments that we have that are FDA approved are based on trials that we did years ago. So, and if the trial shows that the treatment is effective, then that's what's used. And it becomes FDA approved and that's what's used. So each drug has FDA approval based on the type of cancer and the previous treatments that you've had. So that's what we consider standard therapy. And then when we have new drugs, when they go with a phase 3 trial, when we're trying to have a new drug, they compare it with the standard and they want to show that the new drug is better than the standard. So that's what we say by standard is it for all drugs, each cancer has its own standard therapy. So if we have an osteosarcoma, the standard therapy is different than a leiomyosarcoma, which is different than a GIST. But a lot of the sarcomas have the same standard therapies because in the past we were lumping them all together. Now we're trying to split them out and really better understand each individual sarcoma.
Thank you so much. Another patient asked if leiomyosarcoma treatments work on PEComa cells.
Can you repeat that, please?
Yeah, do leiomyosarcoma treatments work on PEComa cells?
So sometimes, so as we talked about PEComa, that sometimes PEComas look a lot like leiomyosarcomas under the microscope. And it's not until the pathologist does additional testing to be able to determine that it's a PEComa. So sometimes when I've had patients where we thought it was a leiomyosarcoma and they were given leiomyosarcoma treatments, and then we found out it was a PEComa. They do tend to respond to similar treatments, but they don't need as aggressive treatments sometimes as leiomyosarcomas. They may not need chemotherapy. They may need, again, we have the new drug that's been FDA approved, and then also pazopanib, so lesser toxic treatments. We forgot about Dr. Forscher, if he's on there. He isn't.
Right.
Doc, he's here.
Okay, if you have.
Yeah, I mean, there are certain drugs like, the PEComas may not respond quite as well to chemotherapy. And that's why drugs like the mTOR inhibitors have been used. There are other drugs like the tyrosine kinase inhibitors where there have been some reports of agents like pazopanib having some activity in diseases like solitary fibrous tumor and PEComa. So they can be used as well, but the target in a PEComa is mTOR. So you'd ideally want to use an mTOR, a drug that's in the mTOR inhibitor class.
We have one more question over here from the audience.
So my question is, on a clinical trial for the data, how long does it take to get shared to the doctors and the patients? And then the other part of that is, I know you said there was treatments that they use that might be primarily used for like a different type of cancer. How does that information get shared? Like one of the chemos my son was on, they told us it was mainly used for kidney cancer, but that's not what he has. So how does like all that other information get shared?
Yeah, so these are great questions. So the first part of the question is, how do we derive information from the clinical trials? So as a principal investigator, so you're one person at the organization that is running the clinical trial will be the principal investigator. Everybody else will be co-investigators. It is the responsibility of the principal investigator to get on weekly or every 2-week calls, rarely monthly calls, to get updates on the clinical trials. If it's a phase 1 trial, the calls are done much more frequently. If it's phase 2 or 3, they're done further apart because you already know the safety information. So for phase 1, early phase clinical trials, you're on these weekly calls and everyone is presenting their patients because typically you only do 3 patients at a time. And you discuss, are there any side effects of these 3 patients? Is it safe to move on to the next group? So the feedback you get very quickly is what is the safety signal? And so if you're coming in to be part of a clinical trial, certainly you will be able to, your doctor should have access to safety information. With respect to efficacy and what's happening with respect to efficacy, often that information is less readily available because you don't want to bias people. You want to be able to have enough patients into a clinical trial to know what's happening. Clinical trials will often have time periods of which they'll stop enrollment, they'll put things on hold, they'll analyze data, and then they'll reopen it again. And so that's called a 2-stage design. So a lot of times the phase 2 are done at 2-stage designs. The phase 3 have what we call interim analysis. So there are time periods where the data is analyzed by an independent group. And that independent group then says, is it safe for the study to continue? Are we meeting the guidelines? And so all of that information can be relayed to you The question I often get from people is, oh, from the patients already on, does it work? That's anecdotal and it's not very useful because if I have a patient where it works in mine, but that's the only patient it works out of 20, that's not useful information for a patient. And so what patients really need is the safety information and then understanding at what point the analysis happens, because that's all predetermined by statistics. And so for instance, we're running a clinical trial with leiomyosarcoma, and we know that we will only put in 14 patients. If a certain number of patients don't reach maybe 4 cycles on the drug, we consider the drug to be ineffective, and then we open it to more patients. So patients could be notified that the drug is now in a second stage, and so they would understand some of that information. But the actual information from the clinical trials gets released. Most of our information gets released in June and November for sarcoma patients. Those are the 2 bigger meetings. Sometimes September as well. There's a European meeting where information will get released. And then as soon as publications happen, patients who are on clinical trials that follow through in a clinical practice usually will get that information from their providers. The second question you asked is, how do you know to use drugs that have an indication for a different indication? And so there is enough data for drugs like, so we could use a drug like cabozantinib. Cabozantinib is an FDA. Perfect. So cabozantinib is FDA approved for kidney cancer. We know from a number of studies in phase 2 that cabozantinib does clearly have a role in certain bone sarcomas as well as soft tissue sarcomas. And so we have all that data. And so when we want to get the drug from the insurance companies, all we have to do is send them the data that exists, so several clinical trials, and the insurance companies will then decide, is it worthwhile to give the drug? And then if the answer is no, then you petition the companies who make the drug to see whether or not they'll provide it. But it's based on the phase 2 clinical trials that this drug has been used. So the phase 2 clinical trials will unlikely get an FDA indication for sarcoma, but we know that it works in a subset of sarcoma patients based on these phase 2 data.
So if you can't get information on possible side effects, is there a place to go? The reason I asked, my son was on that medicine. It seemed to do awesome. We were super happy with it. Then all of a sudden he got blood in his urine, and they were sure that that's probably what caused it. We called back to the doctors that gave it to him in the clinical trial. It took a very long time for them to get back to my doctor and my son's doctor. Now we're like, can he go back on it? And they're like, well, we're not sure that, it will cause a problem again. So I guess my question is, who will know what side effects could happen? And how do I get that information to this doctor?
Yeah, so cabozantinib is an FDA-approved drug, so the side effect profile is very clearly outlined. And so there is prescribing information on their website, the company's website, that would list a insert for physicians on all the side effects, on what testing to do and what frequency, and what the data had shown with respect to what % of patients have X, Y, or Z side effect. And so that information is readily available. It's readily available on the internet, and that would not be something hard. With respect to be on a clinical trial, the clinical trials is like a recipe in some regards. And if you don't follow if you do 1, 2, and skip step 4, well, you can't do 5, 6, and 7. It doesn't make sense. And so perhaps he was on a clinical trial that said, if you come off the drug for X amount of time because of side effects, you can't go back on. If their doctor feels that this drug is deriving benefit for your son, because it's an FDA-approved drug, it's a lot easier to be able to get it off of a clinical trial if you feel that the patient is deriving benefit. If you're on a clinical trial of an FDA drug that is, of a drug that is not FDA approved, then once you get off of the trial, it's very hard to get that drug again because it is not commercially available. Drugs that are commercially available are a little bit easier to navigate. You just have to write letters and petition the companies for those things. Okay, go for it.
A to Z, thank you. From A to Z, what's the average time period before we could see a drug put on the market for an approval?
Oh,
Does it vary?
I don't think you're going to like my answer. is it 6, 7, 10 years?
Depends on the phase, so depends on.
Yeah, so from the drug first has to go through phase 1 testing to phase 2 testing, traditionally to phase 3 testing. Usually, some drugs have gone from phase 2 to the market, but those are very few. The majority are going from phase 1 to phase 2 to phase 3. And so most drugs are looking at quite a while. The drugs that could sort of become a little bit easier, are drugs that are already approved for other indication. And so in the sarcoma world, a lot of times we're borrowing drugs that we already know have an indication. And so let's say we're using a drug that's approved in breast cancer, and then we're testing it. That's a little bit easier because you're not going through the whole process of getting a new drug, you're just getting a new indication. So a new indication is easier. But it's from the first study to the last study, probably decade plus.
That's why it's, you know, that's why being on a clinical trial is so beneficial, because you can't get that drug unless, as Dr. Agulnik said, unless it's FDA approved already, you can't get it without being on the trial. And so it could take, 8 to 10 years. So in that process, you have an opportunity to try a new drug that's not going to be available for a long time in the process, and depends on how rare the cancer is and how fast we enroll patients on the trial. And what the question is, that's how long it takes for the trial to be enrolled and for us to get the data. So as if we have a trial that is for more common cancer, and the trial is enrolled quickly and there's not that many patients on it, we may have some information. Once that they don't release the effectiveness data until everyone's been enrolled on the trial and they've analyzed everything and the trial is closed to enrollment, then they analyze it. So that part takes time. And then but the whole process, is a long time. Brandy had a question.
Yeah, I would just piggyback onto what Dr. Agulnik said about how we tend to reprogram and reprocess drugs for sarcoma, because a lot of the drug companies aren't particularly thinking about sarcoma when they're developing a drug. And Gleevec, which is the mainstay of treatment for GIST, was actually the development process for that was really for chronic myeloid leukemia. And it was only when people realized that there were certain similarities biologically between CML targeting and GIST targeting that people began to try Gleevec and GIST, and it got approved. It just went away.
Thank you. Brandy has a question.
Yes. So my question is, we're going to veer off to placebo. How does that work exactly? How do the patients know they're going to be subjected to placebo? Do they sign up for that and say that's okay, they want that? Or is it just like at random? How does that work?
So any clinical trial has a clinical trial design, and the design would have to be, the patients have to know what the design is. And so if it's a one-arm trial, everybody gets the same treatment. If it's a randomization, it's important for people to know, are they randomized in a 1-to-1 fashion, meaning that for every one patient that gets the first treatment, there's one patient that gets the second treatment. Sometimes it's 2-to-1, so that you have 2/3 chance of getting the experimental arm versus the standard arm. I haven't seen much different than 2-to-1, but usually it's either 1-to-1 or 2-to-1. If there is a placebo part of it, it's usually, you would be blinded, so you don't know if you're getting the placebo. And the placebo could be several ways of doing it. So let's say we were doing a study of doxorubicin and we thought that drug X was good. And so what could happen is that half the group could get doxorubicin with drug X, half the group could get doxorubicin with placebo. So you would know there that you're at least getting standard of care with or without something added. Sometimes it's often in the realm of like a well-differentiated liposarcoma that tends to grow quite slowly, that we feel that you could wait for treatment. Sometimes with desmoids would be benign conditions that you could also wait. There's a lot of watch and wait strategy there. And so in the design of these studies in phase 2, there's one study that's coming up in phase 2 that will be placebo versus drug. So the patient will not know if they're getting placebo or drug, but the patient will know that there is a potential for placebo. So you never slide a placebo in without a patient knowing. That's not allowed. And so patients will sign up knowing full well what they would possibly be getting. But we use placebos traditionally in situations where there are no other drugs to compare it to because there is no standard of care, or in situations where watch and wait strategy is a reasonable strategy. And so if you look at, there was the study of sorafenib versus placebo in desmoid tumors. And if you look at the plots of how patients in the placebo arm did, some of them did better than if they had the study drug. So we only use placebo when we feel it is medically safe to do and medically reasonable to do.
And could I just say that in some studies with placebos, there will be a crossover arm. So if the patients progress, the blind is broken. And if they were on placebo at that time, they can be crossed over to get the study drug. It doesn't happen all the time, but there is that option, and that's explained to patients as well.
Thank you, Dr. Forscher. We have a couple more questions from the online chat and also a comment. So I'll start with the comment. And they said, you guys are doing a ridiculously great job. Thank you. Thank you. Another question was, when interpreting genomic testing, what is the significance of tumor mutational burden value?
So what was the first?
When interpreting genomic testing,
Oh.
what is the significance of tumor mutational burden value?
So when we get the genetic testing or molecular profiling or NGS, I'm going to have to add that to the vocabulary list. They're all kind of the same: next generation sequencing, molecular, genetic mutation. They take the tumor specimen and they test for about 500 plus different genes that are known to be altered in cancers. And one of the alterations is called tumor mutation burden. And so they're looking at, we're trying to figure out if there are any targeted therapies based on your mutations. So we have a couple of things that we can try to see if immunotherapy is effective. So PD-1, meaning looking at the PD-1 receptor, and of course, Dr. Pollack will go a little bit more into detail on that. And tumor mutation burden is another signal that if the levels are high, that maybe immunotherapy could be effective.
Thanks. Another question was, have any therapeutics used to treat lung CA, which might mean lung cancer, been effective in patients with pulmonary metastases?
So yes, it does get to be confusing because when patients with sarcoma have tumors in their lungs that it was originally in the leg or somewhere else and metastasized to the lung, it's not lung cancer, it's sarcomas in the lung. So it's a sarcoma in the lung. Now, there are some lung cancer treatments that can be effective in sarcomas. Like, for example, Taxol, they use the gemcitabine and Taxol chemotherapy, so do we. We have it a little bit different. So some of our treatments are overlapping. There's one kind of sarcoma called an inflammatory myofibroblastic tumor that has a specific mutation, the ALK gene, and lung cancer patients, 10% can also have that. And we actually have, there are 5 drugs for lung cancer that have that ALK mutation, and we can use those treatments for the inflammatory myofibroblastic tumor, but we typically use sarcoma treatments when we're dealing with sarcoma that's spread to the lung, and we don't use lung cancer treatments.
Thank you.
Oh, and just recently, we, apropos of this, we had a patient with leiomyosarcoma who got next generation sequencing and had an ALK mutation. So, she was able to be started on one of the ALK inhibitors for metastatic leiomyosarcoma to lung.
Wow.
And she's had a response. So, the yield with next generation sequencing is low in sarcomas, but sometimes you hit a winner like this. It's not common, but it happens.
Thank you. Speaking of metastases, we have another question that says, I have retroperitoneal leiomyosarcoma that is metastasized to my lungs. I'm not sure if my medical provider has done next generation sequencing or genetic testing on my most recent tumor removed. If they won't offer or cover that service for me, is there a program that can provide that free of charge to a patient? Thank you so much for helping us. I appreciate hearing from all of you experts.
So currently, your insurance company should approve next generation sequencing at least once on if you have metastatic disease. So in certain companies are FDA approved, Caris and Foundation. I believe Tempus is also. So now they won't approve if, say, you had your tumor removed and there wasn't enough tumor specimen to send for the molecular testing. They typically don't approve for you to get a biopsy just for testing. But if there's enough, we try to use the most recent specimen to send. So if you ask your doctor to send it, they should, and if they don't, you want to make sure you're going to a sarcoma expert, because I don't think there would be many sarcoma experts that wouldn't send if the patient asked.
I agree. It'd be an unusual situation if you have metastatic disease and your sarcoma specialist or medical oncologist as a whole does not send off for NGS testing. Just have the conversation. Often patients don't know when it's been tested already. And so it's potentially that it was tested and there is nothing actionable. And so maybe they didn't get the information, but certainly have the conversation. It'd be a very unusual situation for it not to be allowed to be tested. It would be considered standard.
Yeah, and again, if there's not enough if they did send it and there wasn't anything, most doctors would not recommend a biopsy just for that. So, maybe that's the situation, I guess.
Thank you. If a patient has been hugely helped by an off-label drug with a cancer where treatment was mostly historical rather than validated, what can that person do to be of help to others with that cancer?
I think one way to disseminate information is for the physician who's treating the patient to write a case report. And so if there is a situation where there is a drug that helps someone and it is not readily available to the community as a whole for us to be aware of it, then a case report could easily be written up, published, and then that information is out there.
Yeah, I think, you could post it on obviously the Sarcoma Alliance Facebook group, say what kind of cancer you have that you respond. But yeah, usually either the physician will write it up, or if they're in an academic center, there's always, Ivermectin students and residents and fellows that want to write these case reports up. Unfortunately, a lot of times the doctors are really busy and don't have time to publish it, but if we get trainee support, we can. We're trying to do that because it can be helpful. If there's a publication out there, then we can use that for another patient, so that we can, if the insurance company denies it, we can take it, we can use it to help appeal to the insurance company or to the drug company.
Thank you. That's it for online. Oh, never mind. Sorry. Is SBRT really helpful in multiple metastatic lung soft tissue sarcomas? I can repeat if you would like.
So SBRT is stereotactic body radiotherapy. So we have radiation by the radiation oncologist, right? And so there's standard radiation, which usually covers a large field over many days. And then we have the stereotactic surgery, which is higher doses, small and targeted. So we usually restrict that to 1 or 2 spots in the lungs, but say if someone's on a therapy like pazopanib, Votrient, and they have 10, lesions in their lung and everything's under control and 1 or 2 are growing, then we could do this SBRT to those and keep the patient on the Votrient or, the pazopanib. But if many are growing, then it probably wouldn't be worth it to try to do that radiation. Usually we would switch treatment.